Hello, my name is Emily Adama, and today I'll be presenting my nursing capstone case study. This case study focuses on a 68-year-old male who presented to the hospital with new onset AFib, potential GI bleed, and as discovered later in his hospitalization, lung nodules with metastasis. His secondary diagnosis was frostbite to the lower extremities. His family history, unfortunately, was unknown. And then his social history, he's actually living with his daughter and his significant other at their home. His sister-in-law is actually his POA, and he was recently hospitalized for his frostbite, and on discharge he was actually in a swing bed. And that is where he came from to the hospital. As for nutritional history, he has recently lost weight and hasn't been eating as well as he should be, he said. And then medication compliance is unknown. As for his functional assessment, vision and hearing, the patient does have glasses and is very hard of hearing without the use of hearing aids. As for mobility, the patient is a 1 assist due to the confusion and frostbite he was displaying. But the patient also has special shoes that he can ambulate around a room or a facility as needed. As for continence, the patient is incontinent of stool and urine. As for nutrition, again, unplanned weight loss. He hasn't been eating as well as he should be. Again, his social situation is he's living with some family and his significant other at home prior to his last hospitalization and his current hospitalization. And then as for his ADLs, he is a 1 assist just because of the confusion as well as the limitations of sensation in his lower legs. As for his nursing assessment, for the poster, I listed the significant findings of each system, but I will go over each of them in more detail for this presentation. As for a neurological assessment, he is alert and orientated ×2. He only knows the person and situation. He was not able to tell us where he was or the current date. His pupils were equal and round bilaterally. There was a slight delay in accommodation in response to light. The patient is hard of hearing. It did require us to kind of raise our voices or remove our masks to communicate with this patient. The patient does stick out his tongue when prompted and then had normal sensation or sensation within normal limits of his upper extremities. However, there is absent sensation in his feet and lower extremities. For a pulmonary assessment, his lungs were clear but diminished, and then his chest did rise equally bilaterally. For cardiovascular, he had a normal S1 and S2. However, he was an AFib, so he had an irregular rate and rhythm. Radial pulses were +2 bilaterally, and upper capillary refill was less than 3 seconds. However, he did have absent pedal pulses and no capillary refill within the feet. From GI, he had active bowel sounds, denied pain. He did state he had recent diarrhea with some bright red blood noted, but this was not observed over the course of his hospitalization. As for GU, he was within defined limits. However, he was incontinent of urine. As for integumentary, he did have scattered bruising and scratches, but it was warm to the touch and indicative of race. However, he had severe dry gangrene to the feet, shuffling of tissues bilaterally of the feet, redness of the lower legs and that were cool to the touch, and he had a small wound to his coccyx. As for his vitals were oxygen was 96% on room air, respiration rate was 16 breaths per minute, heart rate varied from 86 to 125 just due to that AFib. His temperature on arrival was 100.2 degrees Fahrenheit. His blood pressure was 121/70 millimeters of mercury, and he denied any pain at this time. As for medications, he was on lisinopril, 100 milligrams a day orally, and this is because it turns out his laboratory findings showed that he had a low potassium level, so this is to use to help spare the potassium due to that hypokalemia. He was on metoprolol, 100 milligrams a day orally, and was to hold if systolic blood pressure was less than 100 or heart rate dropped below 60, and this was to help control his rate for his AFib. He was on miconazole 2% ointment, and this was just to help prevent skin breakdown in his peri area just due to his incontinence. It also helps with infection control. He was on Protonix 40 milligrams BID IV just for that potential GI bleed. It is a protein pump inhibitor and it can help actually with acid reflux and GERD. He's on Augmentin, 125 milligrams BID orally, and this is just there was a potential for infection due to his elevated white blood cell count. At the time that we started giving this, we were not sure if it was due to his frostbite or if he had any other infections that we were not aware of. His potassium, he was taking 20 milliequivalents TID orally, and this was because his potassium was 3.0. And then finally, he was on spironolactone, 25 milligrams a day orally, hold if his systolic blood pressure dropped below 100 millimeters of mercury, and this is a diuretic that helps spare potassium due to his low potassium levels. As for laboratory findings, his white blood cell count was 14.1, which is high, and this indicates that there is an infection within the body, most likely due to the gangrene, and then as we later discovered, due to the cancer diagnosis he had. Red blood cells were 2.4, which is low, and this could be due to the potential GI bleed, but also infection and cancer will cause the bone marrow to create more white blood cells rather than platelets and red blood cells, excuse me. Platelets were 22.3, which is low. Again, this can be related to the bone marrow creating more white blood cells to help fight infection and his cancer. Hemoglobin was 8.1, and this could be related again to the GI bleed or his body overworking and producing more white blood cells than the other blood components that he needs. Finally, his potassium was 3.2, which is low, which could be related to his malnutrition, and his calcium was actually low, 7.2. So again, this could be related to his malnutrition or potentially a metastasis of the cancer. As for diagnostic testing, the main thing we had this patient on most of the time while he was in the hospital was he was actually on telemetry to help monitor his AFib and his heart rate. He also had a colonoscopy, which did not show any abnormalities initially. They did do a follow-up one, I found out later, where he actually did have a slight GI bleed, but it was under control at the time. He had a chest x-ray that actually showed lung nodules bilaterally, so they decided to investigate this a little bit further with a CTA, and it actually showed lung nodules bilaterally with lymph node metastasis. So initially they knew he had nodules within his lungs, but now showing that he had the lymph node metastasis was a new diagnosis. Generally, the windshield survey is this population tends to have multiple health problems and comorbidities, so there's a high need for doctors and healthcare needs, and an increase in physical and cognitive decline. Hospitalization seems to lead to an increased risk of depression and isolation, and this can be self-imposed or not self-imposed. Faith and spiritual health seems to be a focus of this population. Family is absolutely a priority during the course of this disease, and being with family and friends during this time to help cope. And then according to the U.S. Census Bureau 2022 of Sioux Falls, 82.3% of the Sioux Falls population are white, and 13.0% of the population are 65 plus, which this particular patient falls into. There are support groups for this population, but actually finding the sources needed does require use of technology unless you go through like community events or health fairs, and this can be up in the air based on the patient. Some patients are very good at technology and how to use their phones, and others struggle with it. As for nursing diagnosis, again, he had impaired ability to walk related to frostbite as evidenced by impaired circulation and absence of sensation in the feet. He's also at risk for social isolation due to impaired ability to walk, confusion, and impaired immune function. And then at risk for infection as evidenced by impaired immune system due to frostbite in the cancer diagnosis. So the priority of the care, at the time of admission, the main thing we were worried about was the GI bleed. So with this, we monitored his stool and labs, particularly his hemoglobin levels, as well as his other blood cell counts. We also had a GI consult and did colon prep and colonoscopy, and this happened twice with this patient. His second priority of care would be his AFib. For this, we had a cardiology consult along with electrophysiology. And so he was on continuous EKG, and then we had medications to help with his rate and rhythm. His third priority was his frostbite. Obviously, we were applying betadine to the lower limbs to help with the tissue drying and sloughing, and assisting the body with the dry gangrene process. We wrapped the wounds as needed. He did have a surgical consult, And the surgeon did decide that should everything go well with his other testing in his course of his hospitalization, and to see where the gangrene actually ended up finally, it could be an amputation of just the lower leg itself or just the foot. And then finally, his cancer diagnosis. Initially, we thought that this was simply just the lung nodules he already had. However, when we discovered that there was metastasis to his lymph nodes, then this kind of shot up on the ladder, but initially it was not the priority at the time. So addressing the problems, public education on caregiver respite and taking time to recover from continuous care of their loved ones is very important. This can lead to fatigue, depression, a loss of focus, and other issues, anger and frustration as well. And this was supposedly the reason why he got frostbite initially. He apparently wandered out of the house and the family was not aware of it and was out for an unknown period of time with improper clothing. So just making sure the family has time to recover and time to themselves so that they can keep caring for their loved one properly. Also reinforcing the importance of yearly screenings and providing adequate information for the reasoning for the test from the provider standpoint. Early detection is key for a disease or an advancement of the disease, and when a patient is regularly seeing a provider for changes to their health or just for yearly checkups, that stuff can hopefully get picked up sooner. So just educating this population on staying on top of their regular health checks, as well as staying in contact with their provider as needed. As for SMART goals or SMART outcomes for this patient, the patient will teach back the importance of using a call light for help by the end of the shift. This is important because he was confused and could be a little bit impulsive. Patient will walk around the room with staff and assistive devices by the end of the second day in the hospital. We just wanted to give him that first day to kind of recover and get used to his new surroundings before we got up and got him moving. Patient will have laboratory results return to baseline by the end of discharge. Obviously, we had some major abnormal changes to his labs, so we really want those to come back to normal levels before we discharge him. And then we also know that hopefully the treatment is being successful. Patient will open up to nurse about feelings and concerns for self by the end of the shift. Initially, he was pretty withdrawn for us, but as the shift progressed, he seemed a little more comfortable being around nurses and nursing staff. A patient will ambulate in the hallways with staff on a daily basis by the end of discharge, so we want to get him up and moving. We want him to walk, even though he does have that lack of sensation, but he does have those special shoes, so we did want to get him up and moving as soon as possible. Patient will adjusting for testing purpose, establish a new dietary baseline by discharge. He is malnourished and is losing weight, so we want to get that back to normal or get him an adequate intake for his health concerns, because we don't want that to keep getting worse. So some of the interventions we incorporated in his care was continued monitoring of laboratory values and vital signs for the duration of the treatment and hospitalization. We assisted with ambulation with the nursing staff for the prevention of bed sores, immobilization, and social isolation. We tried to get him out in the hall. It went well, but not the greatest, but he was able to get to at least the door and turn around. Hospital staff wore masks when working with the patient due to working with multiple other hospitalized persons, so we did not want to spread infection from one patient to another. We also did really good hand hygiene and other cares with him, just so we did not spread infection and compromise his immune system even further. Nursing staff will provide support and comfort as needed for the patient and spend a little extra time throughout the day. We actually did this. We would spend more time visiting with the patient and checking in on him just to make sure he was doing okay and he didn't need anything. And this was also due to his confusion. Family was encouraged to visit with the patient. We did get in contact with his family and had him come in. Nursing would also ask for chaplain visits, and this was actually per the patient. Once he was established in the hospital, he did want to speak with the chaplain on a regular basis. Finally, health promotion. With this patient, there's a big focus on infection control due to their compromised immunity, and it was also important to monitor the patient's laboratory signs and vital signs for improvements or worsening changes. It was also important to help assist the patient with this new establishment of a normal. He was a little stressed when he found out that his lung cancer did metastasize, so helping him deal with this diagnosis and helping him prepare for like a palliative care consult, which his family was present for, and the patient was able to make those decisions. And then the patient was actually very receptive to being in the hospital. He understood why he was there and why being in the hospital was necessary for his health. And then the patient again made the decision when health declined for a transition to palliative care. Cultural considerations. So initially, the patient denied cultural considerations at admission. He didn't really worry about it. But once he kind of got the hospice diagnosis and then that his health was not great and was actually starting to decline a little bit, he did request chaplain visits. And then this was also requested by his family. And then, excuse me, the family actually started making the funeral home appointments and adjustments as needed and arrangements for after discharge, if needed. Excuse me. As for care coordination, so this kind of has two parts. Initially, we were having GI, cardiology, electrophysiology, surgery, hospitalist, pharmacist, and case management all on his case. And this was because of the GI bleed and all the imaging that we had it done, as well as his new onset AFib and trying to figure out the source of that and how we can treat that. So we were doing medications and continuous EKG. Surgery was scheduled for after the full extent of the dry gangrene, once that was fully determined, because we didn't know if he was just going to take the foot or if it would be the whole lower leg. And then again, we had that cancer diagnosis, and then that kind of really changed the priority of care. So after we got the metastatic cancer diagnosis, again, we had all these people on board, but then added the palliative care team. And this was discussed with the family in person, and they decided to get him ready for palliative care and, if necessary, hospice and comfort cares. The patient unfortunately did get to this point, so we did initiate comfort cares and contacted the hospice house and prepared him for discharge to the hospice house. As for evaluation of our interventions, were the interventions successful? Initially, yes, he seemed to be responding well. However, after the cancer diagnosis and knowing the extent of how far that cancer had spread throughout his body, they were no longer successful. And this was because at this point, the patient decided to take a sharp decline in his health and was actively put on hospice and comfort cares by his POA. So we were preparing him for discharge to the local hospice house so that he could pass away peacefully there. Again, medications transferred for mostly like pain measure medications. We had him on oxygen for comfort. All IVs were stopped. We had him in place, but we didn't have anything running through them. We let the family be there as long as they wanted. Unfortunately, before we could discharge this patient, he did pass away in our care right away in the morning. It was very peaceful. He was with his family at the time. I had the opportunity to do postmortem cares, not just with the patient himself, but also with the family. And we allowed them to be in the room as long as they needed to process what happened. They let us know when they left that they were very grateful for him to be in our care and to be part of this journey with them. I did have the opportunity to do those postmortem cares, and I did have time alone with the patient to thank him for personally thank him for being part of my nursing capstone, and that he would be part of my presentation to further my education, and that I loved being part of his care during this really vulnerable time. I also had the opportunity to follow him down to the morgue with the charge nurse and see him off on his final journey. So that was my presentation. If you have any questions, feel free to contact me. I will also have a document that has all the works cited for this presentation, and I will upload them as well. And like I said, feel free to contact me if you have any further questions.